I love this slide because it reminds me of my mother-in-law. And she was a lovely lady, actually. She had diabetes and she had had a heart attack. And her GP had her on all the usual drugs, which she freely admitted to me. She never took any of them. She lived to 94, by the way. Anyway, she went off to see her GP because she had bad arthritis, and the GP had prescribed her some non-steroidal anti-inflammatory drugs. And I said to her, how are you getting on with those? And she said in a very strong Glaswegian accent, I flushed them straight down the toilet. And I said to her, why don't you tell your GP you don't want to take the drugs he prescribed? He's such a nice man, I don't want to upset him. And, you know, if you look at the literature, you will see, you know, that adherence concordance rates in chronic diseases is appalling. And we kid ourselves if we think our patients are taking every drug we prescribe for them, because I can assure you they are not. And I think this is one of the biggest challenges we face. This is another challenge. This is some work we've been doing with Craig Curry and Mark Evans. This is the massive UK GP database, and you can see that between 1995 and 2008 there has been a mean 7-kilo weight rise in both men and women with type 2 diabetes, even greater than in the general population. Add to this horrendous issue of young onset type 2 diabetes, and I'll refer you to a lovely article by John Nolan in Diabetologia last year. The increased prevalence of early onset type 2 diabetes brings clinical diabetes care into new and uncharted waters. The modern obesity epidemic is without precedent. And then the Lancet goes on. Now listen to this one, Diabetes UK. The fact that type 2 diabetes, a largely preventable disorder, has reached epidemic proportions is a public health humiliation, largely rooted in reversible social and lifestyle factors. Medical approach unlikely to be the solution. Medicalisation disempowers individuals, excludes community schools and urban planners who have the potential to reduce diabetes incidence. And the question is, why are we not doing more in relation to prevention in this country? Why are we not doing and achieving the results that they've achieved in Finland with stabilisation of their obesity rates, massive reductions in cardiovascular event rates? And then the best example I can give you is EPOD. Some of you will know about this. Together Let's Prevent Obesity in Children. Unfortunately, it comes from France. It's a community intervention that aims to prevent childhood obesity. A good example of common sense. It was a programme that started in 1992 as a pilot to modify children's eating habits and increase physical activity. During the few years of that study, childhood obesity did not increase in the participating towns. It doubled in the rest of the region. The full campaign was launched in 2004 in 10 towns, involves more than 300 towns in France, and has been extended to lots of other countries. The results have been stupendous. The prevalence of overweight, not just obesity, under 9% in the intervention cities, 18% in the neighbouring comparison towns in line with national trends. Why has it worked? Yes, good organisation, but the most important factor undoubtedly is buy-in from the whole population. And it's not just at a very highfalutin level, the multidisciplinary expert committees, the Mayor's Club, the national institutions and so on. It's not at a national level. It's not even at a regional level. It's at a local level. And we're talking about the involvement of health professionals, teachers, patients, parents, shop owners, catering services, companies, local producers, network of associations, infancy professionals and the media, all buying in. And it has had phenomenal success and has had a major influence on behaviour of children and their families. And it's high time we were doing this kind of programme in the United Kingdom.